Okay, peristernal short. So basically where you were for the peristernal long with your probe marker pointed towards the right shoulder, you're now going to turn it towards the right hip, and you're going to get this kind of image. So a nice concentric circle of that left ventricle. We talk about getting the boxing gloves, which are the papillary muscles, into view as far as the level you want to be at. A lot of people will make the mistake of being at the level of the valve, and sort of don't quite get the idealized view. But this is kind of our determination for another functional assessment of the heart. So what we're really looking at is that circle we see, the one that's sort of, with the papillary muscles in the middle of it is concentrically squeezing. So the idea that you're standing in there and you can imagine that all the walls are closing in on you. If you're working in the adult world, they'll often talk about trying to map each part of the left ventricle in terms of the flow to it. Not something that's super important for us as a rule. And so you can sometimes see if it's a left anterior descending, ischemia, that there's that particular part of the wall that's not, working effectively. So, they'll often use that as a way of gauging and correlating with their ECGs, which part of the heart is involved. And then, of course, we'll talk about the interventricular septum and its relation. So just anatomy there. Again, what do we see here?
Fusion.
So fusion. So you can usually see a fusion from every view, of course, but this is not the typical way we're going to be looking for small amounts of fusion, because it's not looking at the most dependent parts of the heart. And what do we think about this heart?
You can stand in the middle of the day and look into it.
That's right. So it's exactly right. You wouldn't really feel too uncomfortable standing in this room, right? So that if you're telling yourself that, it's a very good chance that you've got some severe functional restriction. This heart.
Dilated.
Hard to make out some of the anatomy and stuff, but I think we can agree that this heart is not squeezing very much at all. So this may be the same patient from before with that dilated LV. You can't really even make out where the RV is here. And then what's going on with this one? Let's see if this is playing through. I don't know if it's very good, Peso. So this would be our D sign. And what's the D sign mean? That's right. So the pressure from the right side is bowing into the left side. Now, what conditions would we typically see that in? So PE. You can also, see it in your pulmonary hypertension kids, right? So for us, PE is obviously not as relevant as that kind of situation. But if you've got pulmonary hypertension in a neonate or in a kid who's got some known congenital abnormalities or cardiac abnormalities, this may not necessarily be a surprising feature in some of those kids, right? Some of them have near systemic vascular resistance in their right side. So again, context important. If this is a kid that's really desatting and you're having a hard time with their hemodynamics, this may be of a lot of consequence. Yeah, that's your D sign. What's going on with this heart? Yeah, this is almost certainly from a patient that's died. So this is just a bunch of clot within the heart. So more of an interesting image than one that you necessarily are using specifically as a reason to use the peristernal short, but you can certainly see the layering there within the heart of clotted blood. Okay, so apical four-chamber. This one's the hardest for you to obtain. Typically, you need to increase your depth a little bit, and you need to find that kind of rib space. And sometimes you actually need to do a few little techniques. So turning the patient onto their left side is probably the one that people think of the most. You can also talk about getting them to exhale as much as possible to get their lungs collapsed, because really the lungs get in the way here. This is our normal view with the four chambers. Right ventricle, left ventricle, right atrium, left atrium. Again, pericardial effusion. I'll breeze through some of the ones that are just effusion stuff. And then what are we seeing here?
Anatomy.
Yeah.
Not the normal one.
So what's on the left here?
Cold, yeah.
Yeah. Well, what do you think? Like roughly speaking, anatomically, what's going on here?
Right.
Yeah.
The left.
So as a rule, your right ventricle should be about 2/3 the size of your left ventricle. As a neonate, that is a little bit different, right? Because neonates have relatively big right ventricles. But this is clearly not a neonate if you're sort of looking at the size of this heart. So this would be a situation where you've got some right ventricular hypertrophy. You've also got just globally decreased function. I would not comment on things like ASDs and VSDs. So yeah, maybe there is, but I wouldn't really get into that. That's a tricky game. Sometimes just depending on the angle, remember the atrial septum is a very thin structure, so you may not necessarily see it clearly. The way that cardiologists will look at them is going to be using flow patterns and that sort of stuff, right? If you have a big muscular VSD, you can probably see that. Or an AVSD, you can probably see that. But again, don't try and be too smart. Trying to get into the anatomical stuff will get you in trouble because, an ASD, whether it's here or not, isn't going to necessarily change the ballgame. Poor function, big right ventricle. What's going on with this one? Yeah, left ventricular hypertrophy. So this is probably like your kind of hokum looking heart. So take-home points, peristernal long is going to be for your squeeze. You're also going to see effusion there and be able to determine where exactly that effusion is. Peristernal short is going to be for the D sign, and again, to look at squeeze. Your subxiphoid, effusion and function. Probably function should be in small caps there. And then four chamber is going to be for comparative anatomy, and again, looking at things like effusion. So you can see effusion everywhere, really. But the 4 chamber probably is the one that if you're really struggling with in the context of a real patient, you don't necessarily need. Like, it's not going to be usually the one that changes much of the ball game. The peristernal short and the peristernal long and probably the subxiphoid are probably the 2, if you're going to choose to do 2 views, that would be your most kind of high yield. Other take-home points, don't sweat the details, which is sort of what I was just saying about that ASD. So getting in there and trying to be like, oh, what's the anatomy? And, trying to do measurements, like looking at what we're talking about next here, that high 5 thing, and doing M mode on the valve. It's all well and good. And if you have the time to do it and it is, sort of something you're doing as an educational thing, that's great. But probably for our purposes, we do not see nearly the same amount of pathology as our adult colleagues. And so getting to be overly detail-oriented about some of the cardiac kind of quantitative stuff is not necessarily a great idea. I mean, if you take some big courses and you get yourself really up to speed on what the cardiologists are doing here, that would be amazing. But in the amount of times we actually have true pathology, probably being overly inclusive is not a great idea. Finding that descending aorta is going to give you a good sense of where that effusion's sitting, and then remember to look for the deadly D when you're doing the peristernal short. As far as evidence stuff, just quickly pointing out that our ability here, this is a paper that came out this year, and it compares physical examination findings with POCUS findings for looking for the same sorts of things. And in general, in almost every case, POCUS findings tend to be a lot more valid and have higher sensitivity and specificities than physical examination findings. So just to validate what you're doing at the bedside.